Welcome to ATCM Emergency Medicine. Today I'm presenting a case, 56-year-old male hailing from Tamil Nadu, a farmer by occupation, no other known comorbidities and not on any other regular medication. He came with a history of fever since 10 days, abdominal pain since 7 days and onset of rash since 3 days. So fever was intermittent, high-grade in nature, associated with chills and rigor. Abdominal pain was diffuse in nature, intermittent, no aggravating or relieving factors, and rash, which initially started on the chest, upper back, and then spread to the upper limbs as well. It was not associated with any itching. This patient had no other history of cough, breathlessness, weight loss, or loss of appetite. He had a history of contact with domestic animals and was a farmer by occupation.
What is the importance of that history?
Increased chance of zoonotic disease.
What disease?
Considering brucellosis.
Brucellosis. What is the common presentation of brucellosis? Might have read in PUOs. Brucellosis is one of the common PUO. Yes. One of the common presentation. One is PUO. What is the typical involvement of brucellosis? Joint pains. They resembles rheumatological diseases. Okay, so we have to be very careful.
On arrival on examination, his BP was 130/80, heart rate of 78, respiratory rate of 23, saturation of 98%, and a temperature of 102 Fahrenheit. He was also having pallor. Along with that, on head-to-toe examination.
So what is abnormality you are immediately watching here? What is the temperature? What is the pulse rate?
Yes, sir. But there's a discrepancy, so there's a...
Okay, that's okay. What you told is 73, no, pulse rate. You told temperature is 102. So what are the problems you anticipate when you get a finding like this? Normally, when you have a temperature of 102, you expect somewhere around 90, 95 heart rate, normally. Yeah. But here you are telling only 72. Yeah. What you suspect in this case? It may be a problem in evaluating the patient, it may be a problem in some drugs. So what are the reasons you suspect? That's all.
Yeah. It could be in conditions like typhoid fever.
It can be typhoid fever. Yeah. It can be patient on drugs. That is very important. You have to ask, is the patient is on any drugs like which can produce the heart rate or beta blockers, calcium channel blockers, digoxin, something like that, and like you told, infections which can reduce the heart rate, typhoid, dengue fever, brucellosis, all these things are also can produce low heart rate, but it is not bradycardia. It is called as relative bradycardia.
On head-to-toe examination, patient was found to have nodular lesions on his upper back, chest, and arms. Along with that, he was having hypopigmented patches present on bilateral medial malleoli as well as on 3 digits of his left hand. Along with that, he was also having a chronic ulcer present 2 centimeters anterior to the lateral malleolus, where there is no active
chronic,
discharge.
Ulcer means discharging ulcer or dry ulcer?
It's a dry ulcer.
So what are the reasons for such dry ulcers? Chronic dry ulcers, what are the reasons? Chronic non-healing ulcer. It's a surgery topic. What are the causes for non-healing ulcers? Reasons for non-healing ulcers? Diabetes. Okay, is he a diabetic?
No, not a diabetic.
Second reason. Okay, venous insufficiency will not produce dry ulcers. It is wet ulcer. Okay. PVOD, they told smokers, all these things then. It's a common question, no? Surgery topic. It's a common surgery topic. Chronic non-healing ulcer. TB. TB is the third one. Okay. TB and leprosy, both. Then vasculitis. Okay. So these are the common differential diagnosis for a non-healing ulcer. So since he is not a diabetic, he is not a smoker. Then other 3 we have to suspect: vasculitis, tuberculosis, and leprosy. Okay. In vasculitis, which vasculitis is common at this age group? Is there a common vasculitis at this age group? What is his age?
56.
56-year-old male. Can he get a vasculitis? Is it common?
Not very common.
Not very common. Vasculitis in elderly individual male, it is not very common. If at all they can develop a, and what is it? giant cell arteritis. Otherwise, other arteritis are not very common in that age group. So you are left with only two differential diagnoses for a non-healing peripheral ulcer, TB and leprosy. Okay, so you have to think like that.
Then on systemic examination, per abdomen, he was found to have splenomegaly. The spleen was palpable 9 centimeters below the costal margin towards the umbilicus. Otherwise, no other hepatomegaly, so no free fluid in the abdomen.
9 centimeter palpable spleen.
Yes. Then on we had sent his blood work, so his inflammatory markers were found to be elevated. CRP of 123, procal of 5.7, ESR of 110. His RFT was normal.
What is the CRP?
123, sir.
123. Yes, sir.
110.
So what is the difference between CRP and ESR? Is there a difference? So ESR predominantly indicates a chronic progressive inflammation. CRP just indicates an acute problem. Okay. So some patients can have chronic inflammation. On top of that, they can develop acute on chronic. So in that case, both CRP and ESR will be elevated. If it is only a chronic like tuberculosis, leprosy, rheumatoid arthritis, only ESR will be elevated. Whenever there is an activation of the basic disease, the CRP can increase. What is the ferritin value?
Yes, ferritin was 1,300.
Okay.
Along with that, his count.
What is the importance of ferritin? Why I asked ferritin? It's also an acute phase reactant. Okay. So when you get a very high CRP, the ferritin is unusually high. So now we have a patient whose ferritin is 7,000. If it is in thousands, we have to be very careful. This patient directly go to multi-organ dysfunction syndrome or HLH like that. Okay. So since ferritin is not very high, patient is having inflammation, but he is not in danger. Okay.
So his counts are 1,100, hemoglobin of 7.7 and a platelet of 54,000.
Okay. What is the problem here? Counts are?
On the lower side.
So what type of cells are predominantly that 1,500 cells?
His neutrophil was 59.5%.
So that is 700 cells. Okay. Is that important? Is that important? Why it is important? Huh? 1,500. In that only 700 cells are neutrophils. So what you are suspecting? Neutropenic sepsis. You are directly.
Neutropenia.
So somebody is having a chronic fever, raised ESR. If the neutrophil counts are very low, what will you suspect? What will you suspect? Huh? Viral fever. She is having a chronic problem. ESR is very high. Counts are low. Neutrophils are low. So that means what? That means what? He is going to bone marrow suppression. Okay. The infection, whatever is there, either it is indirectly or directly affecting your bone marrow. Okay. Not because of the neutrophilia is developing sepsis. Okay. That much neutrophilia is not there. But bone marrow is suppressed. Normally when you have an inflammation, you must have an elevation in the count because it's a reactive state. But you are getting a low count here. That means the bone marrow is affected. And you are getting a peripheral non-healing ulcer. So what will you suspect? What is myelothysic anemia? Myelothysic anemia. Is the HB is low?
7.7.
7.7. So what is myelothysic anemia?
Marrow is replaced by
Which is a common disease. MDS is different. Myelofibrosis, that is. This is myelothysis. Which condition you get? TB. Okay. TB or leprosy. These are the infections which can produce myelothysic anemia. Okay. So any inflammation can produce some amount of neutropenia, some amount of anemia. Everything is possible. Chronic myelosuppression is known in all this infection. But when you have a low WBC count, low platelet count, low RBC count, you have to always suspect a myelothysic anemia. Okay.
Yes. So a patient was initially started on antibiotics, but he continued to have high-grade fever spikes.
What is the indication for antibiotic? What antibiotic you start in this type of cases?
So we had started him on Piptaz initially.
What is your suspicion?
We didn't have a source of infection at that point of time. So
No, what is your suspicion? We cannot start blindly any antibiotic. You suspect an infection above diaphragm, below diaphragm, gram positive, gram negative. No suspicion or what?
at that time, we didn't have any suspicion.
So blindly you have started one antibiotic. Okay.
Then he continued to have high-grade
Is
fever.
there a justification for antibiotic here? You have a justification, but
High
procalcitonin is slightly
inflammatory
elevated.
markers.
So he is having some infection, and we don't know where is the infection. And he is having low neutrophil count, so there is a chance of gram-negative infection. So piperacillin tazobactam is justified. Okay, we should know what we are starting, why we are starting, is it indicated, not indicated, everything we should know. Blindly you should not start any drug. Okay.
Suspecting HLH, we had also sent ferritin, which was 1,300. Fibrinogen was on the higher side, 600.
That means what?
That
High fibrinogen indicates what? High fibrinogen.
is below.
Huh? High fibrinogen indicates DIC. Low fibrinogen indicates DIC. High fibrinogen indicates what? High fibrinogen indicates what? It's a phase reactant. It's an acute phase reactant. It's like CRP, your ferritin, fibrinogen, all are acute phase reactant. So that simply indicates that there is an
inflammation.
acute inflammation going on in body.
Triglycerides was 450.
Okay. So when did you take triglycerides in this patient? What is the time of triglyceride? In
Morning we had taken.
this? Before food?
Fasting.
After?
Fasting.
Fasting. Okay, it is 400.
Yes.
Total cholesterol?
Total cholesterol. We had just sent the triglyceride levels.
Why? Total cholesterol you have to send, no? Should know what is the other cholesterol. We should know what is LDL, what is HDL. Suppose everything is elevated, then you cannot tell it is a hypertriglyceride. It's a dyslipidemia. Okay. So all these things you have to take care. Okay. Just taking one parameter and telling this is HLH may not be correct. That's why I'm telling.
Yes. So we had also taken a biopsy from the skin lesions, the hypopigmented patch as well as the nodular lesions.
Okay.
So while that was being processed, we had done a bone marrow because of the pancytopenia. Bone marrow aspiration was not showing anything specific. It was just showing, it was normal with less than 2% of plasma cells.
Okay.
So by the time the biopsy had come, which was showing infiltrate of foam cells with a type 2 like lepra reaction, which was positive for acid-fast bacilli.
Okay.
So we had initially started the patient because of we were suspecting probable HLH. We had started the patient on pulse dose steroids, IV methylprednisolone 1 gram for 3 days, and along with that we had also started the WHO regimen for leprosy, which was dapsone, rifampicin, and clofazimine. So with that patient,
what is did you examine the peripheral nerves in this patient?
yes, peripheral nerves. There was no thickening of peripheral nerves, but there was loss of fine touch over the hypopigmented patches on the medial malleoli.
Only that area it was lost.
Yes, sir. There was no other thickening.
Any
of
foot
nerves.
drop, nothing.
Nothing. No other residual focal defects. So after starting treatments, the patient improved. His fever spikes reduced. And we had discharged him within 10 days of starting treatment.
Okay.
So he had come for follow-up after 2 weeks and he was found to be improving. He resumed his daily activities. After that, he was lost to follow-up.
Okay. What is the treatment you started?
So WHO, we had started the treatment for lepromatous leprosy, multibacillary lepromatous leprosy for 12 months. So within...
What is a drug? Drug.
Drugs. We had started this thing. Dapsone, rifampicin, and clofazimine.
Okay.
So clofazimine, clofazimine dose.
Okay. Anyways,
Yes, dapsone 100 milligram per day. Because it's multibacillary, we had given it for a duration of 12 months.
what are the adverse effects of dapsone?
It can cause hepatotoxic. It can also cause hypersensitivity reaction.
Hemolysis, hypersensitivity. Okay.
Then along with that, we had started rifampicin, which was 600 milligram once monthly. Clofazimine, 300 milligram once monthly and 500 milligram per day.
Okay.
Along with that, we had also sent him on Visalon and tapering doses.
Okay.
So on follow-up, initial follow-up, he was found to be improving, but post that, he didn't come for follow-up.
Okay.
So leprosy is a chronic granulomatous infectious disease caused by Mycobacterium leprae. It has a predilection for the skin, nervous system, and upper respiratory tract.
Okay.
So according to the host's immune system as well as the duration of exposure, a patient can have a spectrum of presentation. So that comes under the Ridley-Joplin classification. Patients with higher immunity presents on the tuberculous side. So tuberculous, then there is the borderline tuberculoid, mid borderline, mid lepromatous, and lepromatous.
Okay, so depending on the immunity, the tubercular leprosy will be more. Okay.
Yes.
Tuberculin formation will be more when you have good immunity. But the skin changes are more when you have a low immunity.
Yes. There's also the WHO classification for leprosy, paucibacillary and multibacillary. So paucibacillary is 5 or less than 5 lesions along with a negative split skin smear at any site. In case of multibacillary, it's 6 or more lesions and a positive split skin smear at any site. Along with that, the clinical features, patients usually present with, the mode of transmission is droplet infection or through skin lesions. Patient usually presents with hypopigmented patches but can also present with maculopapular or nodular lesions. And chronic duration can also present with skin thickening, nerve thickening and induration of nerves, as well as loss of sensation, particularly fine touch and temperature. So the risk factors mainly, its numbers are more in developing countries because of poverty, low hygiene, and because of lack of awareness about the disease. So the nerves that
is it a small fiber neuropathy or large fiber neuropathy? What is the difference between small fiber, large fiber? Neuropathies are basically divided into small and large fiber neuropathy. What you tell is small fiber neuropathy. Large fiber neuropathy, example, B12 deficiency, folic acid deficiency. They have vibration and joint position sensation loss. Here you have pain and temperature loss.
So diagnosis, before diagnosis, the reactions that are seen in leprosy, there is type 1 and type 2 lepra reaction. So type 1 lepra reaction is a sudden onset of new skin lesions along with the painful and indurated nerves. The main course of treatment is steroids. Type 2 lepra reaction is a type 3 hypersensitivity reaction. Along with the sudden onset of new lesions, there is also systemic features such as fever, can also cause anemia, hepatosplenomegaly, arthritis, and eye involvement can also be present. The drug of choice in type 2 lepra reaction is thalidomide, but because of its side effects, particularly teratogenicity, and it can also cause residual nerve damage, steroids are now preferred over thalidomide.
Okay.
Clofazimine can also be given in type 2 lepra reactions.
Anything else you want to add? Want to ask? Nothing. Nobody knows about leprosy. We think that leprosy is not there in our community, but it is still there. Large number of patients are there, but we are not seeing because we are in a private hospital. Okay, thank you.